My name's Melissa Chaikof, and I have 3 adult children. The youngest and the oldest suffer from Usher Syndrome type 1F. So what is Usher Syndrome? It's the leading cause of inherited deaf-blindness. Depending on the genetic type, they're born with varying degrees of hearing loss, some with absent balance, and they all go on to develop vision loss due to retinitis pigmentosa. So type 1 is the type that I'm going to focus on. That's the type that my daughters have. Within each type, there are subtypes identified by letters that are just the genotype, the gene where the mutation is found. So with type 1, the children are born profoundly deaf at birth. They also have vestibular dysfunction, and they have retinitis pigmentosa, which begins to make itself evident in childhood. With type 2, they're hard of hearing at birth. Their vestibular function is normal, and the retinitis pigmentosa usually becomes evident in their teen years. With type 3, they're born with normal hearing, normal vision, and normal balance, and then gradually begin to lose all 3. I should mention that it is a recessive genetic mutation. So with type 1, I mentioned the vestibular dysfunction. That's a very important characteristic of Usher type 1. As babies, they're floppy, for lack of a better word. The vestibular system is located in the inner ear. You probably know that. It controls how the muscles contract in response to gravity. So if it's not working properly, they don't contract sufficiently, and the child has low muscle tone. One of the first pieces of evidence of vestibular dysfunction in my older daughter, Rachel, was what you see in the picture on the top. At 6 weeks of age, if a baby's lying on its back and you pull it to a sitting position with the arms, they should be able to hold their head parallel to their body. But a child with vestibular dysfunction can't do that. Other traits are, besides the poor head control, are arching of the back as an infant. This all translates to later gross motor milestones, sitting, walking 18 months or later. And then during childhood, the first evidence of the retinitis pigmentosa is they have difficulty seeing at night or in low light. And then they begin to experience a loss of peripheral vision, which isn't just to the sides, it's also above and below, as you can see with the picture on the bottom. I have more information on our website, usher1f.org, if you're interested more in the vestibular dysfunction. But one thing that's really important to know that none of the experts who we saw over the years ever knew was that 36% of children born profoundly deaf with vestibular dysfunction have Usher 1. If you eliminate some of the other causes of profound deafness at birth with vestibular dysfunction, such as maternal cytomegalovirus, charge syndrome, there's a few others, those odds of it being Usher 1 go up greatly. So these are just some pictures of my daughters when they were younger. You can see in this first picture, that's my older daughter, Rachel, her head is to the side. And that's because she did not have the head control to keep it upright. This is my younger daughter, Jessica, doing a combat crawl. They don't have the muscle strength to pull themselves up to a regular crawl, so they start with this combat crawl. This is Jessica. You can see this was her 1-year-old picture. You see her hands are still on her legs for support because she still wasn't sitting easily. One of the other effects of low muscle tone is they're very flexible. And so you can see this here. And then finally, she was just over 2 years old when she could finally walk. And you can see she's got her arms out to steady herself. And here's a video of Jessica. Hopefully you'll hear the sound, but one of the things I want you to notice that is another very typical trait is most babies or babies with a normal vestibular system will stand still and let go before they take a step. Because of the poor balance, they can't stand still. So they walk and they would have the momentum that keeps them going until they just crash because they can't stop and stand still. Okay, get her to stand up by herself. Get her to stand up in the middle of the floor. Whoa! Whoops. There we go. So one of the important things I think, and I've heard it since becoming part of the Chan Zuckerberg initiative from so many parents, is to trust parents' intuition. I noticed that Rachel didn't startle. By the way, I have her referred to here as R because of her career. She doesn't, they know that she has some vision issues, but it's not widely public with her work that she has Usher Syndrome, which is why for something that's going to be posted publicly, I've listed her as R. But I noticed that she didn't startle. We lived in a small apartment, and I would keep her infant seat on a table, a dining table near the front door. And it was a door that was a heavy fire door, and it would close automatically, so it would slam. And she didn't flinch if it slammed. So I voiced my concerns to the pediatrician at her first visit at 3 weeks, and he told me that I was an overly anxious new mother who didn't understand how newborns react to sound. At her 2-month visit, he noticed her poor head control and that she was arching her back. He suspected cerebral palsy and referred us to a pediatric neurologist at Massachusetts General Hospital. We lived in Boston. I don't have a video of my girls arching their backs, but a friend of mine whose son has Usher 1B was kind enough to lend me this video so that you can see it.
Bop, 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 bop.
And I just want to mention, this is actually his cochlear implant activation. He was, I think, 8 months old. And there you see him arching his back.
Very loud. Okay.
So we saw this pediatric neurologist. He did a thorough exam and was puzzled. I was the one who asked him about her hearing. He rang a bell beside her head, didn't get a response, and referred us for a hearing test.
Bop, 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 bop.
I remember the date well. July 15th, 1987, Rachel was 2 months old. The audiologist took her back for an auditory brainstem response test, which the baby is sedated, and they put electrodes on and they measure the response to sound. It wasn't a half hour. The longer we waited, the longer we knew that it wasn't going to be good news. 2.5 hours later, the audiologist came to us and said that our suspicions were correct. She had a severe or profound hearing loss. We didn't know what that meant. We had no previous experience with deafness. We were like, is she deaf? What does severe or profound mean? They immediately sent us with a very cranky, hungry baby to meet with 2 other professionals, another audiologist and a social worker. They hit us right away with, were we familiar with the controversy in deaf education, sign language, spoken language, or both? They were very biased towards including sign language. And so we said that's what we would go with. Fortunately, a family connection changed our path. And we learned about the auditory verbal approach, which is the most auditory of approaches. It's a parent-centered approach where the parents become the children's primary language role models, and with help from the therapist, teach the child to learn to hear and speak using either residual hearing with hearing aids or cochlear implants. We first visited a geneticist when Rachel was 10 months old. He saw that she wasn't sitting. You can see in the picture, her tongue is kind of hanging down. The low muscle tone can even extend to the mouth. He came up with nothing. When Rachel was 21 months old and had just started walking, we visited a world-renowned pediatric neurologist at Boston Children's Hospital. He saw her low muscle tone. He knew that she was born profoundly deaf, and he concluded that a mild flu-like illness I'd had when 5 months pregnant created an isolated insult to her central nervous system, causing her deafness and low muscle tone. Since I went on to have 2 more children, you can imagine how anxious I was about getting sick in those 2 pregnancies. We were very fortunate. In 1989, we were working with an auditory verbal therapist who was part of a network, who was speaking to another auditory verbal therapist in Ottawa, who had a child who was completely deaf, as Rachel was. And they had gone to New York University and gotten the child a cochlear implant. We got the information. We were down there a couple months later. And after an 8-week protocol, Rachel was one of the first 200 children in the US to get a cochlear implant as part of the clinical trials. We went on to have 2 more children. Our son was born with normal hearing and normal muscle tone. And then Jessica came along in 1995. She failed her newborn hearing screening when she was less than 24 hours old. And so we knew at that point it was genetic. We also started to see the same vestibular issues in Jessica. We were with a new pediatrician at that point who commented on her amazing collagen vascular system. I looked at her like she was nuts and said, it's her vestibular system. In November of 1995, we visited yet another geneticist. He didn't suggest Usher syndrome. We had seen an ophthalmologist every year, knowing I was concerned about it. The ophthalmologist looked in Rachel's eyes very closely when she was 15, said they were clean as a whistle. And so we thought we'd escaped Usher syndrome because most children are diagnosed before then. Then at age 19, during a routine annual eye exam, the optometrist, and it was an optometrist at that point, not an ophthalmologist, noticed that Rachel was missing letters at the left and right edges of the eye chart, and then she detected the telltale spots of pigmentation in Rachel's retinas. We knew at that point it was Usher syndrome. Further testing that day, we ended up with almost the whole day at the hospital, confirmed the diagnosis. And then we had one of the worst experiences we've had with a specialist. Our last stop of the day was with the retinitis pigmentosa specialist. Rachel was crying. The specialist yelled at her, "This is severe. It's not very, very severe, but it is severe. How could you not have noticed it?" We never went back to that woman again. We were lucky, was one of the first thoughts that we had, that we hadn't listened to the biased professionals who told us we should teach Rachel sign language. And it wasn't just those first ones. We were badgered by the chief of ENT at the Children's Hospital, by the daycare director, by another social worker, constantly to teach her sign language. We chose cochlear implants and listening and spoken language. As I mentioned, Rachel was part of the clinical trials. And then in 1996, Jessica was the youngest in the United States at the time at 15 months to get a cochlear implant. And so one of the first thoughts that we had when we got the Usher diagnosis was that at least they wouldn't face a dual sensory loss. This is such a clear example as to why early diagnosis and early intervention are so important, because if parents get the Usher diagnosis early, they can make an educated decision about cochlear implants and communication options. So these are videos of both of my girls, both about a couple years ago. Rachel spent 2 years in the Peace Corps in Cameroon, Africa, and this was actually filmed when she was there. One of the things I want you to listen for is the first 3 years of life are the critical years for learning to hear and speak. Rachel missed most of those. She's done incredibly well, but Jessica at 15 months got over half of that time. And so you'll hear a difference in voice quality.
As I am living in Cameroon and working in community health education as a Peace Corps volunteer. But I want to thank you all so much for being so willing to learn more about the genetic condition which I live with every day, Usher syndrome type 1F.
I started to realize my vision was beginning to go at a camping trip with my Girl Scout troop, when all my friends could see by the moonlight and I could not.
Another thing I should note is Rachel was in auditory verbal therapy till she was 10. And even then, once she finished, her language was just about caught up, but not completely. Because of her earlier implant, Jessica finished at age 6 with language that tested age level to 2 years above. So that early diagnosis and early intervention for any deaf child is important, because every month without hearing becomes more than a month of language delay.
As I'm living in Cameroon and working in community.
So my girls today, Rachel's 33. She hears and speaks very well. They both use the phone. She's lived her life fully in the mainstream through grad school. She's fluent in French. She's won spoken foreign language awards in high school. She served 2 years in the Peace Corps in Cameroon. She's married to a man with normal hearing, and she works in global health development. Her vision today, she has lost peripheral vision. Her central vision is still good, but we're in a race against time. Jessica also attended mainstream schools throughout. She's now in grad school at American University, virtually this year, unfortunately, studying sociology with a focus on disability rights. Our foundation, Usher 1F Collaborative, is working to find a cure for their vision, and we are in a race against time. So just to summarize, telltale signs of Usher syndrome type 1, profound deafness at birth and those telltale vestibular issues, difficulty seeing at night in childhood, tripping over objects at their feet, because as I mentioned, when the vision starts to go, the peripheral vision, it's not just side to side, it's also up above and below as well. The other thing to note is that there are certain ethnic groups that have mutations specific to that ethnic group for Usher syndrome type 1. As with my girls, anyone of Ashkenazi Jewish ancestry, approximately 2% of those of Ashkenazi Jewish descent carry this mutation. And I would say about 80%. There are some other more rare mutations, and more are turning up as genetic testing becomes more sophisticated. The other group is French Acadian ancestry, which is Usher syndrome type 1C.
Here we go. This is the story of the power of one. How one little boy can bring so many together, and that happens to be my son Michael P., who's an LGDA warrior. Now it's not, now my, okay. So this is my husband Greg. He's an internist at Johns Hopkins. This is me, Kim. I'm a surgeon, bariatric surgeon, and clinician-scientist. Michael, who's now age 11, and Matthew, who is 10. And this is our story, Michael's journey from our perspective, from the parents. So as I was trying to say, Michael Alexander was born on May the 13th, 2009. And we were so lucky to have him. I did have to do IVF, and that's mostly because I waited to have babies because of my career. And then when I went to try to have babies, I was told I have to do IVF. And so we did several cycles, and we had beautiful Michael. He is 8 pounds, 5 ounces, happy, healthy, and just the most super smart kid you've ever met. And then by surprise, we had Matthew. I had actually started IVF cycles, and Matthew was spontaneous and just a huge joy and excitement to have him. And they're 14 months apart, and they're the best of friends most of the time. Then our lives changed when Michael turned 5. I was in clinic and I got a phone call that Michael had a fever of 104. The fever was for days. He had malaise and also bone pain. I took him to the pediatrician, and just like Melissa said, the pediatrician told me, "Don't worry, Kim, this is just viral. He'll be fine." Well, he didn't get to be fine. He started to have poor appetite, and I kept going back to the pediatrician saying, "This is not Michael, something is wrong." And at first we were told maybe it's behavioral. Well, 2 weeks later, Michael presented with a full body rash and swelling in his right groin. And I don't know if you see, but there was these vein-like things in his groin. And as a surgeon, I really panicked thinking, like, what's compressing, causing this? Again, we took him to the doctor, and the doctor said, this is just viral, he'll be fine. Well, finally, when Michael was really getting sick, they decided to do labs, and they found that he had a platelet count of 110,000, which probably explained why he was coming home from school with these huge bruises. He also was positive for IgM and IgG, for parvovirus, and for med students who've done their infectious disease, that's flat cheek, which is one of the 5 exanthems of childhood, and was normal. And they tested him for all kinds of different infectious diseases, but everything else came back negative. And so the diagnosis was probable idiopathic thrombocytopenia due to flat cheek or parvovirus. However, I kept saying, no, this is something more is going on, because he just was not himself. And I got called to school about pain in his hip, and he couldn't walk, he wasn't eating, and his platelets dropped to 72,000. We looked for explanations everywhere, and I was very grateful and lucky that we were at Hopkins. I could reach out. We reached out to hematology, urology, orthopedics, endocrinology, rheumatology, neurology, GI, pulmonary, cardiology, nutrition, and physical therapy and occupational therapy, but no one knew what was going on. So then our hematologist said, well, Kim, it's probably a good thing we don't know. If we don't know, maybe it'll just go away and your son's going to be off to college. And so we were faced with this watchful waiting versus doing more testing and intervention. Again, the primary care thought this was low platelets, probably due to viral and ITP, but he wasn't getting better. Urology thought that the groin stuff in the scrotum was probably a hydrocele, and yet the ultrasound was not consistent with this, and they thought maybe it was viral epididymitis because he had swelling. So the doctors decided they were going to fix this hydrocele, but before they did that, they wanted to give him IVIG because his platelet count was low, and they thought that this would be a good treatment for the ITP. However, we went through the stress of having this IVIG only to find out his platelets did not bump at all. And so the doctor called us and said, we should go ahead with the hydrocele, but I think we should also do a bone marrow biopsy. And I think both my husband and I, our heart sunk. So then we get to the surgery, and there's our Michael. If you notice, he's always smiling, no matter what. We found unexpected findings. So like Melissa, a procedure that we were told would only be an hour, 4 or 5 hours later, nothing. And then the surgeon came out looking pale as a ghost. She's a friend of mine. And she said, there's no hydrocele, Kim. It was just blood and it wouldn't stop bleeding. So the next day we got results from the bone marrow, and this was markedly hypocellular. And the pathologist was confident that this was aplastic anemia. However, his white count and hemoglobin were normal, and it just didn't make sense to my husband and I. So we went off with this diagnosis of aplastic anemia, had multiple tests, everything was coming back negative, and the doctor said, go and have a family vacation. And off we went to Michigan, and the boys clearly were having fun. But the following day, Michael bumped his head, and he came to his mom, and he developed a small cephalohematoma bruise over his right kind of side of his head, the temporal area. And, as a surgeon, I immediately wrapped it. And so that's why I put this picture, because Michael thought it was hilarious. And then we called the pediatric hematologist, and we rushed to Bronson Memorial, this little tiny, I call it a podunk hospital in the middle of nowhere, and they did a CT scan, which was negative for any type of head bleed, thank goodness. But his platelets were low at 60,000, and what was really incredible, that even though this was a small hospital in the middle of nowhere, the doctor, after a year of looking for answers, ordered a fibrinogen, and that was low, something none of the other doctors had thought about ordering. And while she didn't know what this meant, it was one of our clues later on. So we were sent home and told everything would be okay, but it wasn't. Overnight, I watched as this hematoma expanded, and Michael became very sick. He was crying terrible pain, and he was vomiting. And we rushed him to the University of Michigan, and this is what he looked like. I don't know if you can notice, but there was just this severe bleeding under his scalp, and it was everywhere, and I couldn't stop it. So the treatment at University of Michigan was tough. We had difficulty with IVs. He was only 6 at the time, and he was scared. We had to actually sedate him to get an IV in. And he was treated for disseminated intravascular coagulation. He started to bleed. His platelets were down to 42,000, fibrinogen 52. And though he was bleeding, his D-dimer, as the med students will know, meant that he was clotting too. And so none of this made sense. They thought maybe he had lupus-induced aplastic anemia, and they gave him high-dose steroids, like high dose, 50 milligrams for a kid who was only maybe about 60 pounds, blood and cryoprecipitate, and then they gave him IVIG again. Michael got very sick, tachycardic, fast heartbeat, and the exam, they did a fast exam because they were worried about bleeding, and they saw some weird vessels at his gallbladder, which the doctors had seen before and said were just aberrant variations of anatomy. But one young radiologist, brand new, because this was in July, suggested we do an MRI. And so Michael had to go through a whole body MRI, and that was to rule out blood clots in his body. In the meantime, the final MRI results were not available. Again, we were told it would only take an hour, and it was like 4 or 5 hours. And when the radiologist came to talk to us, he looked pale and said there was some fluffy things in his belly. And so no one told us what was wrong, and I'm not sure whether they were just worried because we were doctors, but they stabilized Michael and sent us home to Baltimore, and my husband looked up the results on Epic. And this is what it looked like. And when I read it, my heart, everything kind of sunk. So it is fluffy. All of this are lymphatics in his belly, in his liver, his gallbladder. And it was read as encasing his SMA and other organs. The diagnosis, diffuse lymphangiomatosis. So when you look this up, and my husband and I in medical school had hardly even heard of this, it was incredibly scary to read. It said diffuse lymphangiomatosis has a poor prognosis and no cure. It's characterized by slow progressive growth of lymphatics, commonly with chylous effusions, and may be associated with lytic bone lesions and mediastinal compression. So at that point, I reached out to everyone and anyone that might help, and that was important. And we were referred to Boston Children's Vascular Anomalies Group, thank goodness. And this is just an example of my outreach. I sent emails to everyone, to Patricia Burrows at the Medical School of Wisconsin, to Dr. Philip John at Toronto Sick Kids, and he replied within 30 or 40 minutes to go to Boston. I then sent an email quickly to Dr. Fishman at Boston Children's, and within an hour he was on the phone with us, which was incredible. So then I wrote to Dr. Adams as well, who is the hematologist that was at Boston Children's, and she asked us if we could get Michael stabilized and to meet us at Boston Children's. And so that's where we went. And while we were there, Dr. Adams confirmed that this most likely was a complex lymphatic anomaly, which is an umbrella term consisting of 4 related but distinct diseases that occur during lymphatic development, usually before 20 weeks of gestation. There are 4 types: Gorham-Stout's disease, which is vanishing bone disease, generalized lymphatic anomaly, central conducting lymphatic anomalies, and composiform lymphangiomatosis, which they felt Michael had. And the way that Dr. Adams explained it is that he had these abundant lymphatics that were overgrowing, and that the platelets and clotting factors would get trapped in them. And that's why he was bleeding. So these are distinct but overlapping phenotypes thought to be explained by underlying somatic mutations within the lymphatic endothelial cells. And the timing of that mutation during development kind of is what makes these 4 distinct phenotypes occur. This is a very busy diagram, but I hope for the med students this will explain some things. So the thought is that there's slow flowing and also fast flowing lymphatic diseases, and they occur on 2 pathways: the RAS, MAC-K, and ERK pathway, and then the PIK3, AKT, and mTOR pathway. And that VEGF kind of links all of these pathways together, VEGF being a growth factor or angiogenesis. What's interesting, and I just wanted to point out, was that GLA is with the PIK3CA somatic mutations, the vascular malformations, and close with our overgrowth syndromes, whereas CCLA is mostly a RASopathy on the RAS pathway with ARAF and EPHB4. And KLA has been found in KRAS and NRAS mutations. As you see, there are lots of other very distinct rare diseases within this whole pathway. What's interesting, though, is all of these are cancer-related somatic mutations. And there are drugs, and most kids and patients are tried first with rapamycin or everolimus, which is an mTOR inhibitor and used in transplant patients. However, they're looking at new drugs like tramitinib, which is used as a MEK inhibitor for melanoma. And with drug repurposing, they were able to use this in a child with KLA, and it actually revascularized his whole lymphatic system, which is incredible. Then there's alpelisib, I can never pronounce it properly, and that's also known as Piqray, which is used for HER2 positive postmenopausal patients. And it's being studied with Novartis right now for close and overgrowth syndromes. And so we're really hoping that some of these drugs that are related to cancer could really help with these vascular malformations. And the reason I want to talk so much to all of you is we really want these young people like you, the young investigators that might be interested in things like cancer. These are the underlying molecular underpinnings. If we can understand, Tie2, mTOR, the VEGFs, we might really be able to understand so much more about cancer. So back to our Michael, he had to get a biopsy. So one of the things about this disease is the allelic frequency in this somatic mutation is so low that we can't find it yet unless there's diseased tissue. And to get diseased tissue is very, very life-threatening for these kids because when you intervene, inflammation, trauma can flare the disease. This cytokine storm kind of thing happens. And so biopsying is very scary. In the meantime, Michael went through his biopsy, and of course he got very sick. And not to go too much into it, but they lost his specimen. This is a kid with 2 doctors, but they lost the biospecimen, and they thought they were going to have to do it again. Luckily, because I am a parent, but also a doc, I spoke up. And I could not believe they couldn't find this. And it was there in the block, and they found it. Later, they did do some other staining, and we started him on sirolimus for KLA. But because of the biopsy, we could not get his dosing properly. And no matter, despite what we were doing, we couldn't get it to the right level. And I had learned from Dr. Adams that there was a doctor at University of Cincinnati named Dr. Sander Vinks, who does PK analyses for sirolimus. And I, as a mom, picked up the phone and I called him directly. I didn't hesitate. And he was so kind and so incredible. He got on the phone, and within a day we had the specimens to him, and he was able to tell us that while we had Michael on 1 milligram, he really needed almost 2.5 milligrams twice a day. And from here on, that's what he's been on. So it was extremely helpful. Then we tried to get off the steroids. So this is Michael when we tried to come off the steroids, and what that represents is his platelets at 20,000. The doctor said that we were going to have to start chemotherapy, and I pleaded with them to try high-dose steroids, which kind of helped. His platelets got up to about 48,000, but then the next day dropped way back down to about 30,000. And so the doctors sat us down and said that he has to have chemotherapy. And so we started vincristine. The question was, how do you give vincristine to a kid with a platelet count of 20,000? They tried to talk me into a port. As a surgeon, I shook my head, no. Then they wanted a PICC line, but Michael loves to swim, and you know, I was worried about all of the risks of infection on a PICC line. So I asked, why can't we do an IV? It's a 5-minute drip. I'll watch it carefully. I got 4 eyes looking at me like, this is crazy, but okay, we'll do it. And so we set it up. Michael would go to the infusion center. He had all the warm heating pads. He had EMLA cream, numbing cream, and then he got stuck with first Freezy spray, and then Miss Allison always put the IV in, and then he was done. We got labs, and then we'd go up to the Peds Oncology unit, and Miss Emily gave Michael his vincristine, and Mom watched like a hawk. Michael would tell you that. And then we'd take the IV out to come back for the next week. We did that for a whole year. And just quickly, because I know I've taken so much time, but this was Michael's wish on the last day of chemo. He asked to wear his pajamas, go to Red Robin, and dance. Not go on, but it gets better and better. They try really hard as rappers. So then, you know, Dr. Adams told me not to read because I would be afraid. And she's right, I couldn't read. But the way that my husband and I handled this, he did all the reading, and I was the one who would reach out to whoever we needed. Well, he read that we could get an MR lymphangiogram to better understand Michael's lymphatic system. And so off we went to CHOP. Michael was, again, smiling. This is a normal lymphangiogram, and that's our Michael's. So just one thing to point out, the doctors were amazing, but I think sometimes they forget that we're parents, and the doctors came in and said, this is the worst lymphangiogram we've ever seen. So again, you know, as parents, we, you know, our hearts sink, but the positive was that Michael really physically looked pretty darn great. And so what you see is just a massive tussle of lymphatic channels that shouldn't be there. There's not a main thoracic duct. So how do we monitor this? Most kids actually, and we're very lucky, Michael's was mostly in his belly and groin. And by the way, when the surgeon tried to do the hydrocele, what she found now when we go retrospectively back was all lymphatic vessels. And so for all the urology people out there, think sometimes that it might just not be that hydrocele if things are atypical. So with Michael, again, kids usually do have lung involvement. And with Michael, we were lucky that it's very minimal, but even so, we started to monitor pulmonary function tests and Michael's was going down. So we did get a CAT scan and luckily everything turned out quite normal. But he gets PFTs and also 6-minute walk tests every 6 months. Well, we finished all of the chemo and we went for a pediatric, just normal visit, and the doctor noticed scoliosis. So Michael now wears a brace about 22 hours a day. And as you can see, it doesn't faze him too much. Then with this scoliosis, we were very much, or my husband, in tune and signed up with the Lymphangiomatosis and Gorham's Disease Alliance private Facebook. And he does a lot of reading with the parents, and thank goodness for the parents, and thank goodness for the LGDA. One of the parents posted their experiences with IV bisphosphonate, which is used for patients with osteoporosis, usually women. And it was used in Gorham's disease, that vanishing bone disease. Well, we asked Michael's orthopedic surgeon and the endocrinologist, could we use it? And they thought it can't hurt. So at that point, again, Dr. Adams had told me about Dr. LaCrasse being a basic scientist and studying possible biomarkers. And so I contacted him and I introduced him to Michael's pediatric endocrinologist, Dr. Janet Crane. And together they started treating him with the zoledronate or bisphosphonate. And what I wanted to show you was, this was Michael's platelet count before treatment. This was with sirolimus and coming off of prednisone. And this is with sirolimus plus the zoledronate. I'm happy to report Michael's platelets are 249,000 right now. His fibrinogen, which was way down, you know, in the 50s, is now running in the 250s, and the last one was 272. Again, with being on the sirolimus plus the zoledronate. And then his D-dimer is almost normal. We're not there yet. It was 0.8, but we're almost there from being as high as 30. And then the cool thing about our Michael was that we enrolled him in every study we could find that was safe. And Michael, with Dr. Tim LaCrasse, we're able to show that angiopoietin-2, which is an angiogenesis factor that we all have, in kids with KLA is extremely high, off the charts. With the sirolimus, it came down, and with the sirolimus plus the zoledronate, it is now in the normal range. So what did this do? Well, the power of one. This one child brought so many people together that they were able to publish a case report on Michael in Pediatric Blood and Cancer. And what was even more cool about this was not open access. So me, who's no longer at an academic institution, couldn't even get it. So I picked up the phone and spoke to the editor of Pediatric Blood and Cancer. Couldn't get him, but I emailed him and told him a story, and he made it open access for us, which is incredible, so that family members and parents can learn about this and know now that there's a biomarker that we can follow in these kids. So what have I learned as a parent and clinician scientist? One, people do work in parallel in silos. Two, one doesn't know what the other is doing, quite frankly. And we as clinicians and researchers are so very busy without enough time in the day to get it all done. It's true, we're so busy. Or we choose to work alone because of politics, money, hierarchy, or the fear of being scooped. However, what this daunting journey has really taught our family, our family, that when we come together, as so many did for us, pulling our amazing minds and resources together for the sake of the patient, great things can happen. And there are so many opportunities and amazing things that come from working together. And with that, we will find a cure. And these are just some of the various researchers and clinicians that we are so grateful for, and thank the LGDA so much. So in August, I stepped away from my day job of being a surgeon, and the president, Dr. Jack Kelly, asked me to join the LGDA as the director of patient-led research. And I'm so excited and privileged to do it. I think this is the most important job I've ever done. And our goal is to get our community together, create a research network, and hopefully better therapeutics and a cure. So from a clinician-scientist, what's my perspective? Well, there really are powers of networks. Cross-disciplinary collaboration is important in every disease. Engage our families and really value their input. As Melissa said, patients really do tell you lots. Challenges to knowledge sharing. It's tough sometimes, and I get it. When you're busy clinically or a researcher, it's tough, but we have to get the word out there and not be afraid. And then challenges to advancing research because of money. The most important is the power of a patient's voice to really speak up and advocate. And so as a surgeon, I will tell you that I was taught, and I hear it still, Steele, common things are common. But you know what? What I've learned through this journey is that when you hear hooves beat, you do first think of the horses, but don't forget the zebras, especially when things present and it's atypical and you don't have answers, because sometimes it really is the zebra. So this is our Michael, and he really is the hero. He has presented at plenary sessions. He doesn't even realize it. He doesn't want anything to really do with it, but he asked if he could to start his own charity. This was grade 2 homework. What would he want to do and how could he help? And he said, I would start a charity to help kids with the same sickness as me and try to find the cure. And then just finally, I hope I have time that it's going to work. I'm going to show you a video that Michael made himself, and it was shown at 2 conferences now.
Come on, walk, Michael. No hands. Walk. Walk. Come on, let's see you. Walk, Michael. Good job. Good job. Good job. Look at you. Yay!
He was trying to steal his brother's taffy. Then we decided to mush him.
To come up. Remember to come up, Mommy.
All right, Michael, we better go see where Mommy is.
Not yet. I'm not finished my work yet.
Okay, are we all done?
Yeah.
Okay.
A 2. A 1, 2, 3.
Hi, Mom. Look, Dad's busted. He had this in the refrigerator. No, 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 blah, blah, blah. He's not letting us eat it, though. Bye, Mom. Is it Dad busted? I'm Matthew and he's Michael. And yeah, and we both own the show. We're gonna put on the Flag and the Prince at 9:30. I'll show you. See, I wrote that myself.
Okay. Tell us what it says.
It says today's show up here, and it's down here it says at 9:30 p.m. The Flag and the Prince. And it's almost 9:40 p.m. So we're
I got a weird rash and my platelets dropped. This is our first time at the hospital and the doctors do not know what is wrong.
I have to show you what the kids
I
named
got a 3.
Michael.
I got a 4. 1, 2, 3, 4.
Oh,
Okay,
beautiful.
yeah, mine is not.
Beautiful. Alex
Mine
is
is
on the back. Oh.
I'm gonna do.
Take me out to the ball game. Take me out with the crowd. Buy me some peanuts and Cracker Jack. I don't care if I never get back. Let me root for the...
So we went to Michigan. And I fell and hurt my head. And my mom just freaked out. My parents rushed me to the Mott's Children's Hospital. They gave me an IV. Did not like those. It fell out overnight, so my mom pressed the code blue button. But the food was really good, so I guess that makes up for it. We went to Boston Children's Hospital and met Denise Adams, and she thinks I have KOA, so we went to have a biopsy. Here are some pictures. We had Halloween in the hospital. Then we went out and had it again.
All the way in. Open up.
I had a pulmonary function test.
In and out. Good. In and out. Big deep breath in. Big blast. Push. Deep breath. Good job. All right.
Hi, Michael.
This is my teacher.
Who has seen the wind? Neither I nor you.
These are my doctors, Miss Emily, Dr. Takamoto, and Miss Allison. There's still
Michael
a lot
being
more.
done with chemo. He's done a fantastic job over this last year. He's been a real trooper, and he likes us all, but he's very just glad to not be coming here as often. So, congratulations, Michael, and we're all going to go ahead and sing. Happy end of chemo to you. Happy end of chemo to you. Happy end of chemo, dear Michael. Happy end of chemo to you. Congratulations. Three times wasn't enough.
Maybe 10 times. How many times? I can't get it. I can stop.
Ready? Stay still. Right here with your gloves, and you're gonna push it right towards C. Keep going. That's it. Right there. Stop.
I'm videotaping you so that you can show everyone what you do. Molly's in there now too.
Awesome.
Superman, but I'm not Superman.
Who are you?
Michael.
Not. Now I gotta try and get off of this. Sorry. the bandwidth must be part of the issue. Yeah. So that's really the end of our story. And I just want to thank you.
Good question. So first of all, we were in the pre-internet era, and so it wasn't as easy to go look something up. I would hope that now, you know, that they would look it up. But we also had ENTs who missed it, or otolaryngologists. And, you know, in fact, we have another family that works very closely with us. Their son is 8 and has Usher 1F. And I had sent our cochlear implant surgeon in New York all the information about Usher 1F Collaborative, included the information about Usher Syndrome. And they happened to be with the same cochlear implant surgeon. And they said, we're concerned about Usher Syndrome. And he was like, it's so rare. I wouldn't worry about it. And this is like, I mean, we adore him. He's one of the top cochlear implant surgeons in the world, but even he didn't get it. And so I guess, you know, the main thing I would say is I would hope that information's more readily available today, and that physicians would look up profound deafness with vestibular issues, and then it would probably come up. It most certainly would.
Awesome. So I always felt that I was an advocate for patients before any of this happened. That's the way I was trained. I was trained in the 120-hour work week, and we sat at the patient's bedside and until the patient was better. And that's the way it was. But this journey has made me even more of an advocate, because I've learned that, you know, as a physician, I understand probably sometimes too much, but I understand it and I can ask the questions. But think of parents that have no background in medicine and having to trust what the doctor's telling them. And that is tough, especially, like, I can tell you, as a parent, when doctors talk to me and they're telling me really tough stuff, some of it goes way over my head, and I'm not a doctor or clinician at that time, and I ask to repeat it. So I think one thing for parents and patients, I tell my patients before I go to the operating room with them, you are your best advocate. Use your voice. If you see something or feel something that's not right, it's okay to speak up and try to understand it. I think that's really what's changed me more. And also, I guess the next thing is collaboration. Not letting the naysayers or people who don't think they can come together figure out a way we can do it, because the most important thing is my Michael and kids like him. And so I try very hard in that respect to think, how can we navigate this? Because the most important thing is we all have the same goal. And I really do believe in stronger together. And there's so many incredible people out there. How do we bring them in? So that's, I think, the things I've learned. And I'm hoping that things like this will get the young students like you excited and want to be in this field, because it's like me, you know, I chose minimally invasive surgery. I didn't know what I wanted to do. I loved everything. Minimally invasive surgery was new and not a lot of people were doing it. And so you can kind of make your way and maybe make it faster to good things. So I believe that with rare disease, with vascular malformations, with that you all have so much smarts, and you can pick something and really, you know, change people's lives.
Well, we're in the US, so our healthcare system and getting insurance approval was, I guess, number one. I learned over the years how to really fight and get what my girls needed in terms of therapies and cochlear implants. And so they got bilateral implants before that was standard of care. I did have an advantage that I didn't mention. My husband is a surgeon who also works in academic medicine and research. So having him was very helpful in navigating the system. But I would also just say, you know, I think becoming a parent shows us strengths that we never knew we had. And that's what I learned, that I would fight much harder for my kids than I would for myself. So, you know, I guess that is that, and as a parent doing research helped me speak to the physicians and having them see that I was getting information on my own and speaking to others and acting as the sort of the curator of information. You know, for one thing, become educated. I mean, I've learned things about gene therapy and retinal disease and hearing loss and audiograms. And it's one step at a time. You know, the family we met with when we first got the deafness diagnosis gave me so much information, I was overwhelmed. But over time, you know, I just didn't stop reading and learning to become an educated parent.
Yeah, I agree with Melissa. I think that for parents, you can't be afraid to ask and to reach out for help. I think that's really an important thing. And if something doesn't feel right, then you can ask about it and feel okay about that. And for the clinicians, I would say it's just really important to listen to your patients. I know how busy we are, but you can learn a lot, and from the parents.
Yeah, that's true. Don't dismiss, you know, I said that in one of my early slides, you know, don't dismiss the parents. They're the ones who are with their children more than anyone else.
I completely understand your feeling, right? You don't want to go above your superior, but you can still make a relationship with the patients. And in fact, you yourself might find out way more information because you have the time and you want to find the time. So work with the patient. And then it's okay to report it back. Maybe, you know, not the senior, but maybe there's a resident working with the senior, and it's okay to report things that you've learned. You'd be surprised sometimes that they'd be like, okay, wow, maybe we need to look into that. And do it, you know, in a curious way. I think that what I love about students is they make me think, you know, and make me want to go above and beyond to learn stuff. So that's one. I think the other is, you know, you have to learn about personalities, and maybe that attending, but maybe there is someone who's very interested in rare disease. If you can find that person, I think that's with anything, guys. You know, I was never in rare disease landscape. I was an obesity specialist. Obesity has its own issues with bias and stigma and finding the right people. And it takes work to find the right people, but when you find them, they can sponsor and mentor you, and they're gonna love that. I just loved meeting students and, you know, working with them and watching them do incredible things. So it's finding the right people and working with them and believing in what you think is really important. And that's what's going to make you a fabulous physician.
I think one of the things that Kim mentioned is really the whole thing about getting the physicians to work together as a network rather than in silos. You know, that's something we're still striving for with Usher Syndrome research, because there's so much competition to be the one to get there first. Mm-hmm. And the other thing I would say is that, you know, as a parent, you know, when I learned that when I didn't get a response that was acceptable to me from a physician, I went elsewhere. You know, eventually found a pediatrician we adored who was very open and listened to what I had to say and what I saw. Similarly with the retinal specialist, we never went back to that initial one.